There's not really a whole lot of different ways to treat diabetes that's new or innovative, but one of the problems with treating diabetes is that the patients have to have time to understand what the disease process is and what it does to the body. And a lot of times the providers don't actually have the time to sit in there with the patients and go through all of those different things. But with the approach that we're using through the Diabetic Learning Collaborative, we incorporate the team members to take on certain responsibilities here, certain responsibilities here, and they fit in all the pieces that we don't necessarily as providers have time to sit down and go through with. Because if you're living in the Delta, you're seeing a lot of patients all the time. So it's kind of like a factory. But now you want to make a perfect shirt as opposed to one put together kind of piecemeal. So with the efforts that the collaborative is doing and getting everybody to chime in, we can get everything that the patient needs at one stop, including labs that we might forget to give or diets that we might need to re-emphasize over and over again. It just makes it work a lot smoother, and the patients get a lot of information at one time. And it takes a load off our backs as well. Well, with the approach that we're using now and with having all of the members in place at one place, as opposed to, say, if we didn't have people here doing foot exams, we'd have to try to get them appointments with podiatrists, or we would have to try to do them ourselves and fit them into the day. Well, with having people from the Learning Collaborative incorporated into that team, including people who do that screening eye exams as well as the screening foot exams, we can get all that done, not necessarily at one time, but we can get those patients back into one place where they're used to going, and that makes it more likely that they're going to get everything they need for their diabetes. Still, compliance is an issue, and we have to work on that all the time, but if each one of us as team members reinforce the compliance issue, then half of them are going to get it. And if we can make a 50% difference in the outcome of our patients, I think we've done a wonderful job. And with the way that the Learning Collaborative is helping us to reinforce that, it aids tremendously. And this is an area that much needs it.
How have you particularly changed your practice as part of the partnership?
Well, I can be very honest with you and say that a lot of patients that you see over and over again that don't do what you tell them, you get a little frustrated with them. And sometimes you get to be less objective with those patients. By having other partners who are collaborating and doing the same thing, I don't have to harp at the same patients all the time about not doing the things that I want them to do. And if they see another person's perspective, rather than a scolding from the doctor all the time, in a more helpful, uplifting approach like some of the partners in the collaborative, I think that makes a difference to them. They start to see that, well, it's not student teacher, it's I'm taking charge of my diabetes and I'm doing this because it's going to help me in the long run. And the more people that give them the same idea, the more likely they are to do what we need them to do to cut down on the comorbid states that they develop with diabetes.
But with just the program we've got, I think, looking at some stats, we've had 276 people referred by the facility that meet the diagnoses that you are covering. And of those, just for instance, in September, we had 30 patients referred to the program. And I know when she gets through with them, she'll have an education packet, and she has to get on their educational level. She works with the nursing staff to let them know, do we need referrals for home health or dietary referrals, or maybe case management and social services can help them with medication or transports, and she helps facilitate those with us. Then she does a phone call when they leave, if we can catch them when they go home. That has been one of her barriers, is being able to reach them by telephone because they won't answer the phone. Sometimes they do, and they almost like they're lonely, and they'll follow back up with her. And I believe it's 24 hours, 48, I think 72, 2 weeks, a month. Then after 45 days, another coach follows up with that patient to make sure their needs were met. Some of the biggest problems they have is this area is very poor, low socioeconomic education, and some of the people end up not able to get transportation to get their medicine. So what she does is help kind of coordinate that with them, or get with the doctor's office and make sure they can get to their doctor's appointment. A lot of our doctors are great. If they see the patient can't afford their medicine, or for instance, if they're on Medicaid and they've used all their prescriptions, they'll give them samples to help them get through so they don't quit taking their meds. But sometimes they have to choose between eating and their medications. Then that throws them into a crisis, whether it be their heart failure or COPD or their diabetes is out of control. So they have to choose. And then the sad part on that, it gets even deeper, is because good food is expensive. If they go and try to eat a lot of good fruits and vegetables, it's easier to go eat cheap. They'll go buy the inexpensive stuff. You can buy a lot of pork chops or a lot of pork cheaper than you can buy ground turkey. So they have to make that choice, and sometimes they're coming from a large family. There's multiple generations living in a household, so that's where the health coach kind of gets with them and helps them with some resources. And the program's been great because we're not seeing some of the same faces again. What she's doing now is trying to help us and then coach our people how to take care of the outliers. We call them the ones that are not in the 5 diagnoses, to help educate them and try to do follow-up phone calls. So with that, the good news was I was able to secure an LPN for case management starting January. So that person's going to help me kind of mirror what you guys are doing with the Beacon program. If there's somebody that comes in the ER that we see as a potential for readmission, maybe you have somebody come in the ER and they're treated and they go home. We're working on a process where we can get Renee to help us in the ER. If we see that diabetes patient or that CHF patient come in through there, or the COPD, because it's that time of the year, she's going to go down there and try to help do a little quick education on what can we do to help you, what brought you in, what can I do to get you to prevent them from ever being admitted or readmitted, which is going to be a huge savings on the taxpayers.
1965, discovered I had diabetes, and he controlled it by meals. I've been on insulin ever since 1987. So I had to be careful about my eating and the energy that is necessary to keep me going. In the morning when I get breakfast, Sunday morning, I have to eat a pretty healthy breakfast in order to tide me over. I had some night problems when I wouldn't eat anything at night. The sugar would go down too low, and that would leave me in bad shape. Well, it has helped me immensely in that he was concerned about having enough insulin to sustain me, and he saw to it that I had enough insulin to sustain me. He's been a close watchman over me. I have to give him credit, not because he was sitting there a while ago, but he has done a marvelous job of it. They called me and let me know the medicine available, my medicine, my wife's medicine. We go pick it up, tell me what it costs and all that sort of thing. It's been quite nice. You see, some people get diabetes, they think it's in terms of it's a terminal disease. Well, it's terminal if you don't treat it right, but if you treat it right, you can live with it. You know, you just can't play with it. It's a reality.